Thank you very much for all the kind introductions. It is true that I've known Richard for quite a long time, so it's been a special pleasure to be here today and to learn that our work evolved actually in some similar directions. I'm the co-director of the Center for the Promotion of Health in the New England Workplace, which is funded by the U.S. National Institute for Occupational Safety and Health as a center of excellence in a program that's now called Total Worker Health, which really started as the idea of what can be gained by integrating health promotion in the workplace with protection from workplace hazards. So you were just talking about health promotion, obviously, which is an important area of public health. So it's been an opportunity for me to expand my horizons, and at the same time, our funding mechanism requires a substantial amount of our resources to go into translational research and dissemination to stakeholders. So here is Richard as now in charge of stakeholder relations within CRE-MSD. It just seems like a perfect set of parallel tracks, and again, I'm very happy to be here and to have the opportunity to have some dialogue with all of you. So something nice was said about all my publications. You don't get that long a list of publications working by yourself. So I have a very valued research team. I've put up a few names here, but it's a large group of people who I've had the privilege of working with and learning from. And I'll just say one other comment by way of sort of introduction. Coming from working on musculoskeletal disorders in manufacturing and in clerical work and in construction and other sectors into research on healthcare workers about 15 years ago with some intensity, it was really quite extraordinary to bump up against such a deeply entrenched idea that healthcare workers should sacrifice their well-being in order to take care of their patients. And to me, it's a really fundamentally contradictory assertion, because if healthcare workers are in pain, if they're stressed, if the work environment is not facilitating them working well, how are they going to take good care of their patients? So part of the challenge, I think, in the dissemination and the translation of research findings in this sector is to think about how can we make this evidence persuasive to the decision makers in healthcare institutions, the managers and the people who are allocating resources. So this is actually, I think, a very important challenge for public health as a field, because we're concerned about the quality of health care and we're concerned about the well-being of employees. So we have two reasons to be thinking about these issues, and I hope that you'll give me some suggestions about how we can be more effective exactly in meeting that challenge. So I am specifically today going to talk about the results of 10 years worth of funding, which has produced a project which was called ProCare, Promoting Caregivers' Physical and Mental Health. This has been a partnership with a large company of long-term care services. And I have to say, I learned last night in Canada, this is a little different. So in the United States, long-term care, nursing homes, and skilled nursing facilities, those are essentially synonymous. So I'm going to go among those three terms, and if to you they mean different things, I hope you'll cut me a little slack, because I probably won't be able to remember not to do that. So we worked with this chain of nursing homes, skilled nursing facilities, which implemented a safe resident handling program and which opened the door to us doing a very comprehensive, multi-faceted evaluation of that program. And then as we got near the end of the first 5 years of research, we started uncovering more complications, which you'll hear about. And so it raised some bigger questions for us about differences among centers, even though they all belonged to the same company, and looking at some of the kind of larger questions led us very quickly to this issue about the relationship between employee health and safety and resident well-being as well as other characteristics. And in fact, again, there's been some groundbreaking work, I would say, in Canada in thinking about kind of leading indicators. What can we intervene on early to prevent bad things from happening? And those bad things could be to the patients or to the workers or both. And so this is the kind of the sets of questions that I'll then come to as we moved on in our second 5 years of funding, which we're in the process of wrapping up right now. So this company implemented, as I said, a safe resident handling program, which was quite well thought out. It had very detailed policies and protocols. I won't flesh them out in detail, but I'll just say that this is a third-party company that created this program, which was then implemented by the nursing home chain. And the third-party company is a group of nurses who had seen what can go wrong when a program isn't well designed, how the idea can be implemented less than successfully when there are obstacles in the workplace. So they really thought it through quite well. And we were very impressed just at the very beginning. We were very impressed by the depth of the analysis that lay behind all the details of the program itself. So as I said, we started out with the question of, is this program effective, and how do you define effective? So there are lots of different ways you can think about success of this. And then we kind of happened on the question of whether effectiveness varied either among centers or at the level of the individual workers. And then that led us to some questions about the implications for resident satisfaction or clinical outcomes. So as you can see, over 10 years, we did a lot of work. This was really a pretty ambitious undertaking. So we made direct observations of direct care staff, nursing staff working in patient care. And we used those observations to characterize ergonomic exposures, which is the first set of results I'll show you. We then analyzed workers' compensation claims and costs. This was the big motivation for the company to implement this program in the first place. So we looked at injury rates as well as recurrences of injuries, and we also looked at return on investment of the program. So we had an economist who conducted those analyses. We also did a large number of surveys of individual workers in a large number of these facilities, and some of the data that I'll show you, there are many papers that we've published out of that, but two that I'll show you quick excerpts from are about workers' self-reported use of equipment and low back pain. And then we looked at the relationship between employee and resident outcomes from another set of surveys conducted by a different third-party company that surveys thousands of nursing homes around the United States every year. And we also extracted data from the Center for Medicaid and Medicare Services, which is the government agency that oversees long-term care and to which all nursing facilities have to submit data every quarter about their resident status. So you can see we had many different types of data, and I will try to get through this efficiently, but hopefully without being unclear. If there's something I say that really doesn't make any sense, it's fine to raise your hand and ask for a quick clarification. So the direct observations were using a method that we actually developed a couple of decades ago within my department to have a systematic observational protocol for observing workers' postures, activities, tools, and handling. That's the PATH. And specifically, we customized it here to add whether or not workers were using resident handling devices, lifting equipment, in addition to their ergonomic features. And we made these observations. There's this little timeline is going to keep showing up on these slides. So we made these observations at baseline, which was literally the week in each center when the first all-department meeting was held about the Safe Resident Handling Program being brought in. So that counts as the intervention date. And then we had follow-up observations at 3 months after baseline, 12 months, 24, and 36. Some of the surveys went on even longer, you'll see later. And the data are collected in a categorical form, so this is just one example what the trunk posture categories look like. So they're a little bit crude, but it permits us to make visual observations. And our protocol involved making following each worker around for hours at a time and at 60-second intervals, recording what the person was doing, their postures, and so on. And you can see we collected thousands and thousands of data points, which then get summarized into some hopefully useful results. So, for example, we found that some of these centers actually had some resident handling devices already in place when the program began. So the use of lifting equipment is not zero at baseline. It's at about 10% of observations, and there wasn't much change in the first few months, but then you can see that the use of equipment during resident handling work increased steadily over the course of 3 years. If I showed you the graph just for transferring, that is taking the resident out of the bed into the wheelchair, or from the wheelchair to a chair, or from the commode into the wheelchair, that percentage of tasks in which the equipment was being used was much higher. And you can see that the frequency of high weight in the hands went down notably over time. So these increasing bars are for the lowest weight category, and the highest weight category went down. That's all good. That's what we were hoping for. Similarly, trunk postures improved quite a bit. So this is the increase in the percentage of time in which the trunk is neutral. A person is standing upright, not twisting. And you can see decreases in moderate flexion, severe flexion, lateral bend or twist, with or without flexion. So all of these were changes in the right direction as well. And we had similar observations for arm postures, that less of the time the arm was elevated at shoulder height or above. And also, interestingly, there was no increase observed in the total proportion of resident handling time, even though how much time it takes to use these devices is often cited as an objection against them. We did not see that increase in our observations. We put all these different pieces together to compute a physical workload index. So this red line, and don't worry about the units, they're kind of arbitrary, but this red line shows you the physical workload index score for nursing assistants while they are performing resident handling, and you can see it's a quite notable drop down. So there's a little getting used to the devices in the first 3 months, but then a very notable drop, and this is essentially loading on the lumbar spine while performing resident handling tasks. So a really tremendous drop in that exposure. And just to sort of anchor that, the orange line is for all nursing assistant work, whatever they're doing, pushing a cart or getting a meal on a tray. And the green line is for nurses, RNs, and LPNs who in nursing homes don't perform much resident handling. So they have much less loading on the spine. So that's a good story. But then this is really interesting. In 5 centers where we made repeated observations over this 2-year period, the slope downward in the physical workload index, so the kind of summarized trend here for this red line, you can see it's much steeper for this center B and almost as steep for center D, but for the other 3, it's much closer to flat. So there wasn't the same decrease, there wasn't the same relative decrease in physical workload over time, which was the first indication we had that there were these differences that we really hadn't anticipated, because again, the same program, same protocols, no reason why there should be this level of variability among centers. So looking kind of post hoc, just at these 5 centers, we found that this particular center that seemed to have the biggest benefit in terms of biomechanical loading on the spine of the individual workers, they also had, according to the employees themselves, less time pressure, better communication among staff, and more access to equipment and devices when they were needed. So there were organizational features, which also varied among the centers, that seemed to be predicting what the kind of moment-by-moment exposures were of the individual workers. Okay, hold on to that thought. So now, as I said, the workers' compensation experience was an important motivator for the employer. So these are data for the rates of injury claims for clinical staff, and specifically pulling out the claims where resident handling was coded as the cause of the incident. And the rate of those claims in the up to 3 years before the program was implemented was about 9 per 100 person years, dropping to 6 per 100 person years, pooled across a couple of hundred facilities, 136 facilities. So a quite notable decrease in the risk of resident handling related injury claims. Most of these were back injuries. We looked at some of the subcategories of types of injuries. So these were the all resident handling. And we actually separated this into the first 3 years after and the second, because in the first 3 years, the third-party company was in charge of running the program. And then after 3 years, they handed it off to the individual centers to manage it. So we were really curious whether the company could continue keep the program effective after they didn't have someone else doing it for them. So the good news was that, at least as measured by workers' compensation claims, the answer was yes, because you can see that the rate of all resident handling claims stayed low. And then looking specifically at some of these subcategories, claims where the incident was coded as helping in and out of bed, those went way down after the program. So these are all before, after. The rate ratio of 0.5 means that you've halved your risk, right? So those went down and stayed down. Helping in and out of chair or toilet went way down and stayed down. And the same for the resident handling not otherwise classified, so we didn't get a subtype there. The help move in bed didn't really change. It stayed about where it was before the program. And then you can see this quite unexpectedly, help in and out of bath. The rate went up and then went up even more, and we don't have any idea why. I really can't tell you. And we haven't been able to figure that out with the company either. The help move in bed, so this is not about lifting someone out of bed, this is repositioning. And this can be actually quite strenuous because you're having to lean onto the bed, you're leaning down, you're leaning forward, so it's biomechanically quite disadvantageous. And there are low-tech devices that reduce friction, slide boards and slip sheets and things like that. And these were also part of the program. There were devices like this that were purchased in addition to the whole body lifts. But we actually didn't see them very often when we were out on the floor making observations. We don't really know what happened to them. Did people take them home? Did they get thrown out? Did the residents take them? We don't know. Did residents' family members take them home? We have no idea what happened to them. They weren't chained to the bed. We know they were purchased. We don't know where they went. But we didn't see them in use. So then it didn't surprise us so much that the help move in bed risk didn't change over time. But it wasn't something the company had been monitoring on its own at this level of detail. So that was important feedback. So going along with the decrease in rates of injuries, of course, we expected to see a decrease in cost as well. And in fact, our economist has published that paper a few years ago. She estimated that the total savings to the company in the first 3 years after the program was implemented was $4.5 million a year, US dollars a year, that the program would pay for itself between 1 and 2 years after implemented, and the range is because there were, in addition to reduction in costs of compensation claims, there was also a reduction in employee turnover, which is very expensive, but we don't assume that all of that was necessarily due to this program, and there are also different ways to attach a dollar figure to what the turnover costs. So we played around with some different numbers, and we used the smallest one to be as conservative as possible, and still the program would more than pay for itself within 2 years. And to put it in terms that have meaning to the nursing home administrator individually, the average net savings is equivalent to $143 per bed per year, which is quite substantial. Cash flow is always an issue in this industry. And you can see, again, a tremendous amount of variability from one center to another, all within the same company. So 61 centers that realized savings, 49 that didn't. Of the ones that realized savings, some of them saved an enormous amount of money over this 3-year period, and some of them saved very little, and conversely, there were some that had lost money during this time. That was also extremely surprising to us. So we started digging around into that. How can we understand that better? And we found a few different patterns. So one is that in the in the facilities that had by then accrued more than 5 years of experience with the program, they had much higher savings. So there's some maturation of the program. There's some institutional learning. I don't know if anyone here has knowledge about the kind of organizational development issues and organizational psychology. But this is clearly a piece, I think, of what's going on here, is the learning and the incorporating the program into ordinary daily practice. Then there's another piece of this which is really quite intriguing. So some of these centers also had workplace health promotion programs in place simultaneously with the resident handling program. So this is centers without workplace health promotion, average net savings of about $30. Centers with simultaneous workplace health promotion programs, average net savings about $180. Enormous difference. But here's the really strange thing. When we looked separately at the workplace health promotion programs, we actually didn't find much evidence that they were achieving their goals of reducing smoking or increasing exercise or weight loss. So how could they have this enormous impact on the effectiveness of reducing back injury rates if it's not through those mechanisms? So this brought us back again to questions of the larger work climate, because when we looked at some of the other survey data, we found that these centers also had, according to the employees, better social support, lower intention to leave the job, so there was higher job satisfaction in the centers, which makes me think it's, okay, what is the workplace health promotion program a marker for? Maybe it's a marker for an administration that is concerned about worker well-being, and even though what they're doing isn't having that much effect, the desire to create a more health-promoting environment is somehow being experienced by the employees in some other way, even if they're not stopping smoking or getting more exercise outside of work time. So again, I think a topic that really has been looked at a little bit here by Dr. Yazdani, but which really needs to be dug into quite a bit more, and which we're hoping to continue to do in future work. So I mentioned another aspect of what we examined was in recurrence of back injury. So you may know claims where individuals are absent and then return to work and then have recurrences. These are compensation claims that are far more expensive, both in terms of lost wage replacement, what's called indemnity, and also in terms of medical costs. These tend to be much longer absences with the recurrence. When the person is hurt a second time, people have a much harder time coming back to work. The medical costs may be much higher. And so this bar chart, and no one has really looked at this kind of secondary prevention aspect of safe patient handling programs before that we're aware of. So please correct me if I'm wrong, because this paper isn't published yet, but it's under review. So here's the reduction in resident handling related injury recurrences over this 9-year time period before the program and then the 2 after periods. No change overall in the recurrences of non-resident handling. Resident handling claims specifically causing back injury, the recurrence rate went down, and again, not so for claims that were not associated with resident handling. So fairly impressive changes there. And again, we did an economic analysis and found just looking at the numbers of recurrences. So if you think the number of recurrences would have continued as they were, but we had this impact, so the difference, right, it's like the difference between the height of this pale blue bar and the yellow one, right? That space is the avoided cost. So if you compute that out and add it up, the total 6-year savings for all avoided recurrences was about $3.8 billion US. So per year is this number, and per center is about $4,500. So again, a very substantial savings for a center with maybe 100 or 125 employees. Okay, next piece of the study was the self-reports of back pain and also self-reports of resident handling equipment use from surveys. So we surveyed thousands of employees at a couple of dozen of these centers, so about 10% of the company overall. We couldn't afford to do all 200 nursing facilities, but we did collect thousands of data points. And we have here pulled out the survey data for 8 centers where we did 4 surveys, now over a longer follow-up period, so at least 5 years after the program was implemented. And this is about, first of all, just the frequency of equipment use according to the respondents themselves. So you can see the good news is about 2/3 of them said they use resident handling equipment often or always when they were handling residents. About 20% said sometimes. That did go down over time. These to me represent a real opportunity for intervention, because these are people who either aren't motivated or they're not sure how to do it, or even though they've been trained, or external circumstances may be impacting them more than other people. And then a pretty small proportion, this is very good news, from 10% down to 5% eventually said never or rarely. So quite high equipment use, corresponding also to what we had observed that I showed you earlier. And then with some fancy multivariable modeling, we identified factors at the individual level that were associated with use of equipment. So 3 of these are kind of personal characteristics. I expected the program to be successful, so I used the equipment more often. Health self-efficacy, some of you may know, is the idea that I can do something to improve my health, to protect my health. So again, that's not really surprising. It's perhaps a little bit of a self-fulfilling prophecy. But that's a thing to think about. How can we enhance that? And then interestingly, older workers were actually a little bit more likely to say that they use the equipment. So whether that represents having seen people be injured or having themselves had back pain and recognizing the value, or maybe just sort of feeling a little more vulnerable as you age to the possibility of injury. And then there were 3 work environment characteristics that predicted people's likelihood of using equipment. One was their perception of the institutional commitment to the program, and this was at multiple levels. So it included my supervisor supports people to use the equipment. If I have input about the program, it's listened to and respected by people above me, and also I support my coworkers in using the equipment. So it was kind of a multi-level score. Very interestingly, because I think there's a tremendous interaction between resident handling and the issue of being assaulted by residents, those who had not been assaulted at the workplace recently were more likely to use resident handling equipment. And I'll come back to that topic. And then, kind of surprisingly, lower supervisor support was associated with higher use, but I think there was some negative confounding between that and the institutional commitment. So then we asked, if you don't use equipment when you're handling residents, what's the reason? And the 2 biggest ones were device unavailable when needed, that's these bars, which bounced around a little bit up and down, but are in the range of 20 to 30% of the people who answered that question. And then the residents dislike them, which is a pretty constant 15% of responses. So those were really the big two that needed attention. The other three, not enough time, takes too much effort, my coworkers don't use them. They were small and they went down quite markedly over the course of the program. So that may be part of the institutional learning, is those things becoming less of an obstacle over time. And interestingly, even among the people who said they always used equipment, these two issues of the residents dislike them and the device isn't always available, those remained as high responses, which I think means I always use these devices except when. And this is really important because these are the people who are really motivated to use them, who are really trying to be consistent, and yet they're running up against these obstacles. So these are very important places for us to intervene and help the program be more successful. Okay, and then just to sort of close the loop with the workers' compensation claims, we wanted to also look at self-reported back pain. So we asked about that in the survey. You can see that overall the prevalence went down from baseline to 5-year follow-up. It went down a bit, not enormously. It went down about 20% or so. And then we did a lot of modeling of these questions in several different analyses. This paper has just been accepted for publication. So the key, that the red star here, is to draw your attention to people who use the lift equipment more often were less likely to have back pain. This is 2 years after the program had gone in. There was also this kind of residual association with higher physical workload, variability in workload, as well as psychological job demands, which does overlap a little bit. And again, the association with physical assault. So people who'd been assaulted more recently were more likely to have back pain. Whether that's mediated through lift use or not, I don't actually know. And then looking at follow-up over a 5-year period, where of course the numbers dropped off quite a bit from baseline to follow-up, but you can see that the impact of lift use frequency is even greater there. So it's observational, it's not a randomized clinical trial, but it's a notable apparent impact from as much as we can determine. And then the last piece of what I've promised you is about the relationship between the experiences of nursing home workers and residents. As I said, these data come from third-party surveys. We didn't collect these surveys. They're completely independent of our estimate. They come from an enormous database of thousands of nursing homes where we extracted the data points that apply to the centers owned by this company, and we computed center-level averages for employee satisfaction and resident satisfaction, and center-level rates of resident falls, pressure ulcers, and medically unexplained weight loss. So these are obviously objective adverse outcomes to residents, and those are data that are reported to the federal government every year. So this is just the simple XY plot. Average employee satisfaction on the x-axis, average resident satisfaction on the y-axis. You can see a pretty nice trend. A lot of people talk about this issue. Not enough people have been able to produce empirical data. So this is, I think, really noteworthy. And this paper also, I hope, is very close to being published. These are obviously, these are the 5-year average values. We did the same analysis with multi-level analysis of year-by-year data and found the same trend. So essentially, for every 1-point increase in employee satisfaction on this sort of arbitrary index that goes from 1 to 5, for every 1-point increase, you have about a 1.7-point increase in resident satisfaction that corresponds to that. So that's important because nursing homes, at least in the United States, compete with each other for market share. even as manufacturing companies do. So resident satisfaction is a very important feature. And in the multi-level models, employee satisfaction explained about 25% of the variability in resident satisfaction, which is large. It's quite impressive. We also looked again at the associations with these objective outcomes. So this is taking employee satisfaction score as the predictor. Again, kind of think of it as on the x-axis. So you can see that the risk of adverse resident outcomes goes down as the employee satisfaction score goes up. So that's also quite compelling because nursing homes are rated by the Center for Medicaid Medicare Services. You can look up any given nursing home on the website and you can see how well does it do in taking care of its residents. And so if there's something you can do to improve reduce the risk of these outcomes, that is again going to impact your competition for market share, basically. So then we took this even further. We said, we have data on so many different characteristics of these nursing homes if you pull it all together into one pot. So we used cluster analysis, which is sort of like correlation or analysis of variance, except that you're grouping the observations, not the variables. So this was a way to see how many groups of nursing homes are there. If we say make the groups as similar as possible according to this set of characteristics. And we ended up with basically two clusters. So the blue ones are kind of the good ones, if you'll permit me to oversimplify. So they're above 0 basically on the x-axis, and the red triangles represent the nursing homes that are not doing as well. And there's a little gray area in the middle, but there's not a phenomenal amount of overlap actually. And so hold on to the blue. Blue is good. And so that's cluster 1. So the cluster 1 nursing homes, which are about 60% of the total, they have higher employee satisfaction, higher retention, annual retention of nursing aides, also by the way of LPNs and RNs. They have higher staffing ratios, which has been shown to be associated with both quality of patient care and other outcomes in healthcare. They had lower rates of pressure ulcers, falls, and medically unexplained weight loss, and they had higher resident, family, friend satisfaction and higher survey ratings, which is one of the scores that's produced by the Center for Medicaid and Medicare Statistics. And then we did a post hoc comparison looking at all the other variables we hadn't put into the cluster analysis because we were worried about weighting and things like that. And again, as I said, higher retention rate of the other clinical staff, so a bigger change in the workers' compensation claim rate relative to baseline. So cluster 1, the claim rate went down. Cluster 2, the claim rate went up. So remember, there were some centers that didn't have a benefit from this program. A higher rate of return, well, a positive return on investment from the Safe Resident Handling Program, whereas the cluster 2 basically did not see a return on investment. Better, this is another one of the CMS ratings, and then also, interestingly, they were more likely to be unionized centers. So a whole range of organizational factors coming into play that are associated with the literal day-to-day experience of the aides handling patients in their rooms, getting them on and off the toilet and in and out of the bathtub. So again, just such a great place to be having this conversation because I know that some of these issues are often under discussion here as well. So summing up, so we found that resident handling equipment use increased, exposures decreased, compensation claim rates and costs decreased overall, turnover rates decreased. So overall, the really good news for the company, yes, your investment was very worthwhile. Look at all of the different ways in which the physical work was improved and the costs to you as the employer were improved. And look at all this variability among these different facilities, all belonging to the same company. So these characteristics of centers, which can be improved upon, the first four at least you could think of as kind of predictor variables. You could think of these as leading indicators. These are things we could try to improve and we could expect to see a better return on investment, separate from whether you've bought the right equipment, right? This is kind of the context in which that equipment is being used. And then the latter two are more like lagging indicators, I think, maybe not. It's a little bit hard to tell, but certainly they ought to be quite motivating to top leadership in terms of where they put their resources. And then lastly, the variability among workers. How do you use that? Are there ways that we can provide training in different areas that can help to address some of these issues? Is some of the between worker variability a function of individual supervisors and their supervisory styles? Are there ways that we can improve supervision quality to address some of the differences that we see among workers even within the same nursing facility? And then some other things I'll just note quickly in terms of room for improvement. So the lack of what happened to the low-tech slip sheets and transfer boards, the problem of devices and equipment not being fully available, even though supposedly the right number was purchased for every resident in each facility. The issue of adequate staffing, which directly impacts time pressure, which, as I mentioned, has been highlighted quite a bit in research on healthcare worker health and safety. The issue about residents not liking the devices. So there are nursing homes where when you bring in a new client, actually part of the education of the resident and or their family members is to say, we have this program, this is to protect our staff, and you get a benefit too. This way your mother or your grandmother is always going to have a consistent caretaker. That person isn't going to need to take time off for injury. They can be fully there and feel confident that they are doing their job in taking care of your beloved family member without putting themselves at risk. And this company, for reasons that I really am ignorant of, hasn't made that one of the features of their program, but I think would probably be well advised to, because it remains an obstacle to devices being used. And then the issue about assault, because we've found in here, so this is an epidemic in healthcare workers in the United States. I don't know if it's as big an issue in Canada, but it's huge in the United States in every kind of setting, outpatient, inpatient. It's quite common in nursing homes. We could have a whole sociological conversation about that, but it's quite common in nursing homes. It's associated with back pain. It's associated with nursing aides being afraid to use lifting devices. And there's apparently something about the proximity of the physical contact between staff person and resident that puts them at risk of being lashed out at by someone who's unhappy or angry or frustrated or just doesn't like the fact that they no longer live at home or they're paralyzed or they can't do some of the things that they used to do. So that's a piece also that I think needs a lot more attention. And the connection between these two, between resident handling or patient handling and assault, I think really deserves a lot more attention. So why don't we have public policy about this if there's all this evidence? What do we need to do to get that evidence translated into protection if it's so obvious that this is the right direction to go? So there are a number of national organizations in the United States that have been way out in front, that have provided detailed guidelines for what patient handling programs should look like, including FGI, Facilities Guidelines Institute, is actually a branch of the American Hospital Association, which has published minimum standards for the design and construction of hospitals and outpatient facilities and long-term care facilities to make it easier to use lifting devices. And and as well specifically occupational health and safety professionals. And actually a national, a federal bill was introduced in 2009 and then again in 2013 and then again in 2015. And if you are aware of what's going on in our Congress, you won't be too surprised to hear it hasn't gone anywhere. But there has been an attempt to create federal legislation that would protect healthcare workers. But since that's not happening, some of the states have moved ahead with their own laws or regulations, most of them understanding that it's not enough just to buy equipment and stick it in the back of a linen closet, that you really need a comprehensive program that ensures that the equipment will be used, and that you also need to be collecting data and evaluating how well it's working and finding out if there are things you need to fix. So we don't have a law like this in Massachusetts yet, where I come from, but I was privileged to be on a task force for a couple of years that tried to do some data gathering and generate some of the local evidence for this. And you might be aware we have some world-class hospitals in Massachusetts, but we also have a very high rate of healthcare worker injury. So what is going on specifically within the state of Massachusetts was of interest, was of concern. So one of the things that we did was to survey all of the hospitals. So hospitals are actually licensed by the Department of Public Health. So when DPH sends out a survey, you get a good response rate. They pay attention. So we got a very good response rate on this survey of hospitals within the state. And I tried to just pull out a few bits of the findings, although I think I put too much on these slides. But sort of the bottom line is 44% said they had a written safe patient handling policy that was actually in practice. Another 22% they were in the process of developing one. 34% just said no of them. Some actually had a safe patient handling committee, even though they didn't have a written policy, but 16, that is about 20% of the total number of hospitals who responded, didn't have either a committee or a policy, which was really surprising to us because we like to think of Massachusetts as being kind of state of the art in terms of healthcare. The hospitals that had programs were doing a pretty good job of getting staff input on the selection of devices. They did a better job of assessing events when there was patient impact. If the patient fell during handling, they were more likely to go investigate and understand what had gone wrong. They were a little less likely to follow up if it was only the worker who had been injured. There was a lot of variability in this says safe patient handling policy component. So there was a lot of variability in what elements each hospital had within their policy. Mostly they were pretty strong on the clinical practice side. They were a little bit weaker with regard to making sure the equipment was always available and working. There was not such good reporting of near misses or incidents that could have led to injury but happened not to in a particular situation. Similar to the nursing home we worked with, there wasn't as much in the way of patient and family education as would have been desirable. And there was, this is kind of an interesting problem. So actually minors, under federal law, minors aren't allowed to do certain kinds of jobs that are hazardous, and using hoisting equipment is one of those. So sort of paradoxically, employees under 18 actually shouldn't use patient handling devices because that falls under this big category of hoist equipment, which is potentially dangerous. So the optimal solution is to say those young workers shouldn't be doing patient handling, shouldn't be putting their backs at risk either, but that is something that most of the hospitals weren't aware of and weren't addressing. And then I think maybe I'll wrap up here, but so this kind of pulls it back to some of our nursing home findings. So these were questions in the same survey about why, what do you see as barriers to addressing patient handling within your facility? And the respondents were not frontline workers. They weren't the nurses or the nursing assistants. They were, well, we actually didn't know in many cases, but it could have been the HR director who filled out the survey, or it could have been an employee health nurse. So it could have been someone with knowledge of the program, but not necessarily. And so you can see perceived increase in time required to use appropriate equipment was actually the top vote getter. Now, in our survey, that was in nursing homes, so maybe that's different from hospitals, but we actually didn't find over time that that really was a big problem, but it was from these hospital administrators or whoever the respondents were, they did see that to be a very big issue. So whether that's actually grounded in fact or not, we aren't certain of. They also thought it was very hard for staff to break habits. Again, our data would suggest that over time that's really not such a big problem. That's an initial hurdle, but you can definitely get through that. Cost, of course, was of concern. Again, return on investment is pretty good. So you do have the initial outlay, but if you're going to make it back within a couple of years, you probably could manage that unless you're a very small community hospital that has cash flow issues. And storage space and room size are also understandable issues. So where are you going to keep the lift devices? Are they going to be easily accessible or buried behind other things? Is the room big enough to bring a portable lift, a whole body lift into the room? How does that impact your patient census if you have to have fewer beds in a room in order to have room for the lift devices? And of course, you're going to have less income. So it is an economic issue very much as well. And it's, again, hard to fix unless you're designing or renovating a facility. So we made a bunch of recommendations to the hospitals about implementing programs and doing surveillance and evaluation. We made recommendations to workers' compensation insurers and consultants and the architects who design facilities and people who provide training. We made recommendations that the task force made recommendations to the Department of Public Health about staying on top of this issue, following through. And in fact, now there is a working group with many different stakeholders involved, and we're actually doing focus groups of different parties. So we're doing focus groups of hospital administrators and of employee health nurses and of frontline nurses, trying to understand from each party's point of view, again, what are the obstacles that they see, and then we're going to compare and see how do those line up and what does that mean in terms of activities that the Department of Public Health should promote in order to move forward with prevention. So that's it. I know I covered a lot of ground very quickly. A fair amount of this has been published, and I'm certainly happy to provide reprints to anyone who's interested. I thank you very, very much for your attention through that long saga, and would welcome any questions.
Thank you, Laura. I'll let you handle questions.
Sure.
Questions from the floor?
If you can remember anything I said. Jack.
Yeah, thanks, Laura. That was a lovely, comprehensive, showcase of how simple physical intervention can have financial, care impacts, that it becomes this big multifactorial issue. It's lovely, especially when it's successful. That's always lovely to see.
Yes. You're always happy to have a basically good story to tell. Yeah, fortunate.
There is some weird blips in the graphic, your 3-month period, right? For both the weights handled and your low back scores, they all went up at 3 months and then tailed off.
Yeah.
Why do you think that is?
I don't know. I think that some of so if you remember the reasons for not using, the not enough time, too much effort, my coworkers don't use them. Those were the first survey where we included those items were at the 3-month point, and those all were notably higher than they were later on. So this is where I feel reasonably comfortable saying, you just have to tough it out through that learning process, that things are awkward, there's maybe some resistance, the 3-month point was the deadline for every nursing aide to pass a kind of a competency evaluation for using the equipment. So there was a lot of hands-on instruction, but you had to demonstrate that you knew how to use all these devices to keep your job. So whether that meant that people were working more slowly or more awkwardly up until that point, I don't know. There are always data points you collect that you don't use, and then there are other things you say, oh, I wish I had been prepared to study that in more detail. And I wish we had been able to mount some focus groups right around that time period and see what people thought later, what the frontline workers thought then and later about what that was about. You may have ideas, and I'd love to hear them.
It's fascinating, your answer, because then I go back to Richard and Bob, that had that paper that showed the increased time and increased cumulative load when they're using these devices. But
Right.
how long was that?
That was a snapshot.
Yeah, it was
That
a
wasn't
snapshot.
longitudinal.
So I wonder if it's just that learning phase of using it, that they're slower, and that once you get over that 3-month hurdle, then they become efficient at using the devices. It's almost
Yeah.
a skill component or something.
I know. We asked if there was any way to assess that, and we were told no. People either pass it or they don't. And if they don't, then they don't stay. So there wasn't really, the comparison group is gone, the control group's gone.
Yeah.
So we didn't, in fact, they couldn't, I also asked, could you please tell us who the trainer was at each facility so that we could group on trainer? Because I can't believe that every trainer is equivalent, even if you put this, right? You have different teachers, and even if they're covering the same material, some people are just better at explaining things and helping you grasp the concepts and the skills. And so even though it was the same curriculum, I couldn't believe there was no difference among trainers, but they wouldn't let us have that information. So we couldn't look and see whether one trainer was better than another. And they just kept saying, oh no, of course not, that can't be. Yes?
Thanks for your talk. At several points that you sort of alluded to the evidence around potential importance of resident characteristics. So I wonder if you've done anything to do some risk adjustment at the facility level for the types of residents facilities are serving, because you probably want to be sure you control for that, and it's almost certain that case mix will differ between the organizations.
Yeah, that's a really excellent question. So we did several different things. One is that for the center level analysis, so we have to do all this at the center level. That's one thing, because of issues about confidentiality of resident data. We don't have one resident at a time information. We have pooled at the center. So we have the proportion of residents whose stay is reimbursed by public funding, Medicaid or Medicare. So we adjusted for that in all the center level analyses that I showed. We have downloaded data on activities of daily living scores, and those also we're in the process of computing kind of center level indices. I think, for example, how much assistance residents need to ambulate, right, to move. That would be presumably extremely important for this particular topic. So we are going to put that into the mix and see if it differs.
Yeah, so I think Nursing Home Compare does have ADL data.
They do, exactly. That's our source of, right.
It probably also has RUG scores on, which will give you a good comprehensive case mix adjustment that you could use.
Perfect. Thank you. Great. Good. Other thoughts? Yes?
This project has been fairly long, and two observations. One is it's tough to get funding for these long studies where the effects can become obvious.
Yep.
But the second piece is perhaps because of the earlier date, you didn't mention sealing devices, which are used more frequently now, perhaps. Was this company not using those, or had they moved to those, or was there any idea of moving to those now?
Yeah, this company, I think it's fair to say, didn't buy the Cadillac devices. And that's even within the range of the portable devices. I had a picture at the very beginning, didn't I? The portable devices that are, I guess the portable devices that roll around from room to room. That's what they had. So this, as you can see, is a device that rolls under the bed, and then you roll it away again. So you move someone not from an overhead track. So even among this set of devices, I think there are better ones. But the ceiling lift systems are definitely more reliable. I think they last for much longer, and they don't pose some of the same problems about how much space you have within the room, because you aren't having to bring this thing in around the bed or the chair or the toilet or what have you. But the company didn't make that kind of outlay, and they haven't, and to the best of my knowledge, they're not planning to.
I guess for the study, it makes it a little stronger in that even with a fairly minimal set of devices, you were still seeing effects.
Yes, I mean, I don't know if I call this minimal, because they purchased quite a lot of them. It wasn't just, one per center kind of thing. It was, but yes, they could have done better, and they probably would have seen even greater benefits. So for them, they're satisfied with what they achieved, but from a larger context, I think that's right. If you spent more money on better devices, I think you would probably have a greater return on investment. You might have to wait a little longer, but I think you would realize it within a relatively short period of time. I wanted to say two other things about this sort of maturation thing, where it's always nice when your findings converge with somebody else's. So we have a postdoc who's just done a meta-analysis of safe patient handling programs in hospitals. Erin Teeple, I think it's in press now. And in the meta-analysis, they showed that the programs that had been in effect for the longest when they were evaluated had the greatest reduction in injury rates. And there was also a paper a couple of years ago that some European colleagues worked on, Sven-Erik Mathiasen and a couple of other people. I want to say I can find the reference list later, but they did a kind of a Markov simulation, and they predicted that it would take 6 years for the maximum benefit in terms of reduction in low back pain. So both of those quite reassuring. Yes?
Laura, thanks for the great talk. I appreciate that. Laura, given this is in this total worker health program and the health promotion piece, I didn't see a lot of, what's the feeling, I guess, in the group of what's happening there, and how do you sustain a total worker health program given health promotion isn't seen a lot of things?
Yeah, I didn't tell that part of the story so much. So we did analyze. I showed you one slide that had the centers that were running the company-sponsored workplace health promotion program. That was a pretty low-resource effort, and it wasn't one that the company sustained for a terribly long time. So, as I said, we didn't see a lot of benefits in terms of personal health behaviors where you would have expected a little bit, but a little bit of a reduction in smoking, but really not much. But a good program really takes a lot of resources, and this one didn't have those kinds of resources invested. There was actually a third arm to this study, which was that the company, in addition to, I have to say, providing us with enormous amounts of data, as you can see, and phenomenal access for observations and surveying and answering dozens and dozens of questions every year. They also permitted us to pull out 3 facilities where we actually implemented a participatory, what they ended up calling health and wellness teams, but which were really kind of founded on participatory ergonomics principles. And where we put in front of the workers the idea of, you know, your health is impacted by so many things at work, things outside of work, let's talk about that whole range. And the workers found this a very natural idea. Not in the, I mean, they weren't hung up on disciplines about, you know, health promotion and occupational health. They were like, yes, let's talk about the whole mix. There's this and this and this. And they were very enthusiastic, actually. They started out with kind of easy things, well, what we thought would be easy, like getting healthier food in the vending machines. And then they moved on to sort of scarier stuff about quality of communication and quality of supervision and whether their supervisors respected them and whether they could really have some input into how things were done. And then they got closed down, basically, as we backed off, which was in the plan that eventually we would back off and we would try to support them from a little bit farther away. They all got repurposed into other committees. So we have now a whole different protocol for kind of bringing a program like this into effect. We've had much greater success in, my colleagues within the center have been doing an intervention study in corrections sector, which is, that's another hour, but that's a really challenging setting to work in, and they've had phenomenal reception by both the union and the management, by both the corrections officers and their supervisors. And from that, we've actually packaged up what we call the Healthy Workplace Participatory Program, which is on our website in user-friendly form with a toolkit and little training videos, and that's been developed with an eye to how do you keep it, how do you help people embed it within the ordinary day-to-day operations so that there's some hope of it being sustainable when the researchers go away. And the new study we've just been funded to start in healthcare is going to be a sort of like a cluster randomized trial, except it's only 6 facilities, but 3 pairs of facilities where we've got a control group, and we're going to be evaluating this program that's on our website. We're going to be evaluating it in that design. So I'll come back in 5 years and tell you how that went. I mean,
great presentation. I really enjoyed.
Thank you.
Just follow up on that. Do you think the companies that they had those health promotion programs, they had a structure in place, they had perhaps some experiences of what works but doesn't work, that helped your program to be more successful in those organizations? I mean, achieving more return on investment. So do you think those companies with that experience and that system in place, although may not be that effective, but would help to facilitate kind of your approach, your program to be more effective?
Would help to facilitate our participatory program? Well, we did it in centers that didn't already have a workplace health promotion. So the 3 arms were centers with no workplace health promotion program at all, centers that were using the company-provided materials, and then 3 that would have been in the no group, but they let us come in and make trouble. So I don't know. Maybe, I don't know. Something good was going on in the centers that had the workplace health promotion programs, but I think it was more kind of in the general work climate. So yes, that might have been fertile ground for doing some other things, but certainly we saw that they had more effective safe resident handling programs, which was really, really interesting.
There was one
Yeah.
last question.
Yes. And anybody who needs to leave, if you have another class or whatever, obviously you can go. It's fine. Yes, question. Yes?
Just going back to the actual training program itself. So what was composed of that training program, and why do you think that program was successful? Was there because of the training program?
Yeah, that's a really great question. So I showed this very fast and I went on. So it was more than just training. So first of all, the third-party company came in and assessed the residents, their ADL levels, their medical needs, and their weight, because if you have heavier clients, you need stronger devices that can support their body weight. So the third-party company said to the nursing home company, facility X needs this many of the whole total body lifts and this many of the sit-stand lifts and this many of the slide boards wherever they went, I don't know, and this many of the total body lifts that can support a resident weighing 400 pounds and so on. So that was kind of the first step. But then they also had a set of protocols for sort of all the things that they had observed that could go wrong. So they came and inspected the facility, and they asked what was the physical space where the batteries were going to be put out every night to be recharged. Like they required enough storage space for the number of batteries that corresponded to the number of lifts that were being purchased. And then the same thing for the slings. They actually required to see where was the space where the slings would be hung to air dry after they were laundered. So they were very, very particular about kind of all the things that could interfere with because it isn't just the devices itself. You know, you have to launder a sling after one resident has used it. And if you're using a device all day, the battery's going to run down. So all of these things had to be attended to, and they were very particular about, you know, show me where you're going to do this. That's not enough room. You're not going to be able to fit all the batteries. Your lifts aren't going to be working. And then this part about label on each resident's chart. So each resident, their chart was stickered. This person needs a sit-stand lift. This person needs a total body lift that can support 400 pounds. So every chart and they were color-coded. So even if the nursing aide didn't have a high level of literacy, he or she could look at the sticker and know what device they needed if they were going to get that person out of a chair and back to bed. And then there was, as I said, there was the training about how to use the devices, and each staff person had to demonstrate that they could in order to hold on to their job. So it was really quite multifaceted. And a lot of it was about the larger environment. It wasn't only training.
I know, I'm really happy you brought that up, coming from the healthcare sector and implementing this exact kind of thing right now. It's critical that it's not just training, and I think that's one of the biggest impacts right now to this program is you can't just train someone and expect them to go back to their unit and use these techniques if they don't have the equipment, they don't have the accessibility, et cetera. So
Exactly.
that up, 'cause I think that's
Yeah.
really important.
I'm really glad you asked about that. Yeah, good, thanks.
I'm going to have to cut it off here.
Yeah.
But first of all, I'd like to thank Dr. Punnett.
Oh, thank you so much, Richard.